Welcome to another EduMed video, and this is another in the series of talks about the ITU ward round. And in this video we'll be talking about infection, which stands for the I in the ABCD approach. We'll talk a little bit about the septic screen, which is very common in intensive care, and the principles of minimizing infection on ITU, and then finally some commonly missed points when thinking about infection. When thinking about the septic screen, it's worth thinking about the source of infection, and these are slightly wider than that which you would see in patients on the general wards. The usual things like the chest, the urine, gut bacterial translocation, ascites are quite common. However, the other things that we will often see are patients with pleural effusions which become secondarily infected and become empyemas. Those patients with CSF infections, which again is fairly rare, but especially in patients who become profoundly immunosuppressed, they can get secondary CSF intracranial infections. Abscesses and collections are important differentials, and you should have a low threshold for cross-sectional imaging of the patient if there's infection of unknown source. Lines are a very common source of infection, and they should constantly be reviewed, both for whether they're necessary or not, and also whether they need to be changed. And in general, after 3 to 5 days, we should be thinking about changing central lines, and after 3 days, we should be thinking about changing peripheral lines if we can. Ulcers and pressure sores can sometimes be hidden, especially in the sacral region, and so a thorough exposure of the patient and fastidiously looking for these is really important in trying to prevent ongoing indolent infection, which can then end up with quite significant bacteremias and potentially even endocarditis. Endocarditis is not uncommon in intensive care, and we need to be vigilant of it, and therefore thorough examination of the chest and the heart sounds is important, and also getting rid of any intravascular devices such as central lines if they're not needed is paramount to good care for these patients. In intensive care, patients are often on cocktails of antimicrobials, and the problem with that is that it can increase the risk of them developing Clostridium difficile diarrhea, and if they do get that, they can get quite bad necrotizing enterocolitis. So always be on the lookout for patients who are getting diarrhea. If they are getting lots of loose stool, stop their laxatives. If they're continuing with diarrhea despite stopping the laxatives for a few days, then do think about infective colitis. One small proviso is the inflammatory markers could be going up, but they may have something other than an infection driving that. And one common thing is blood clots. And patients can get deep venous thrombosis, not just in the legs, but also in the upper arms, especially if you've got lines like PICC lines or subclavian lines in situ. So always be vigilant of blood clots as a cause for a raised CRP and even low-grade pyrexias. When doing a septic screen, it's fairly similar to that which you would do on the ward, in that you would do blood, urine, stool, ulcer swabs if there are them there, and wounds if there are them. But the slightly different things in intensive care is we would often take drain fluid and do something called a non-directed bronchial lavage. Non-directed bronchial lavage essentially means you pour some saline down the endotracheal tube, you put a suction catheter down, and then you suction that saline back up. So it washes out the bronchioles and the alveoli, and if there's any bacteria sitting there, we'll then have a better chance of being able to culture that. If you're worried about line sepsis, the first principle is to take that line out. However, when you do take the line out, it's worth just cutting the tip of it off and then sending it to the microbiology department so that they can swab it and see if they can grow any bacteria from it. And if they do, then it'll give you a better idea of what the bacteria to target with the antimicrobial therapy. There are also certain investigations that are worth doing in patients who have a septic screen done. Chest X-ray is vital for these patients, and ventilator-associated pneumonias are very common. But ultrasound is also a helpful technique, especially looking for pleural effusions which may become secondarily infected, or looking for collections in the abdomen, or even just ascites when getting spontaneous bacterial peritonitis. CT scans are the gold standard for looking for abscesses, and you can use Doppler ultrasound to look for any blood clots, especially in deep veins, which may not be visible on examination. More nuanced scans, like white cell scans, have sometimes been suggested for patients. However, the honest truth is intensive care patients tend to have a general level of inflammation that renders these white cell scans fairly difficult to read, and rarely do they pick up on foci of infections that we've missed with other modalities of investigation. And then the final thing is a bronchoscopy, which you can use to actually have a more directed way of getting to certain areas of consolidation that are picked up on the chest x-ray, and then you can put the bronchoscope into those exact lobes and wash them out to try and increase the yield of bacteria from that area and to have a better diagnostic certainty of what the causative organism is. There are a number of principles in minimising infections in intensive care, and they have to be adhered to. And in your ward round, it's really worth just checking off each and every one of these. A lot of these are nurse-driven, but for you to be able to check it as well is worth it, because sometimes people can forget to do bits. Having the patient up at 30 to 45 degrees is really important in trying to prevent ventilator-associated pneumonias. The theory behind it is the secretions that pool in the patient's oropharynx can either come out the mouth, go down the trachea, leak around the cuff of the endotracheal tube and aspirate into the lungs, or go into the esophagus. By sitting in the 30 to 45 degree head up position, the likelihood is that it will drain downwards and drain into the esophagus and therefore into the stomach, and won't just sit there pooling in the oropharynx and getting infected. It's also worth maintaining loose secretions, thinking about whether the nurse is able to get the secretions that you can hear in the chest out. If you can't, then using mucolytics, nebulized saline, and even using a nebulized mucolytics like N-acetylcysteine can be helpful and is vital in trying to prevent infection, because if we have secretions just sitting in the lungs in a warm, moist environment, they're almost inevitably going to become infected at some point. Having close suction for endotracheal tubes is really important. What this means is that you've got a suction catheter that's built into the angle piece of the endotracheal tube connection. And by doing so, you can just continuously suction without having to open the circuit to air, and therefore risk microbes and other things coming into the endotracheal tube. Chest physio is vital, and it's the only way to really get rid of some of these difficult to clear secretions, and without clearing the secretions, the chest infections will not get better. Mouth care is also really important. Again, by decontaminating the mouth, you reduce the risk of bacterial seeding down through the trachea, around the cuff and into the lungs. Regular turning of patients will prevent patients from developing ulcers, which are a secondary cause of patients developing infections and bacteremias, and pressure relieving mattresses go with that. Often these patients can be intubated, ventilated and sedated for many days, and if that is the case, they won't be moving around spontaneously. So by having pressure relieving mattresses, they can constantly relieve the pressure on certain areas of the body and therefore keep the skin intact. From your perspective, whenever you're examining a patient, you should wash your hands before seeing the patient, wear gown and gloves while seeing the patient, and then get rid of them appropriately. This will prevent transmission of infection from one patient to another. If you do have a patient with loose stools, it's worth thinking about infective colitis, but do remember that most patients are on a laxative in intensive care, and as such, the first move should always be to stop the laxatives, see what happens. If the diarrhea doesn't stop after a couple of days of stopping the laxatives, then think about sending the patient's stool off for investigations such as the C. diff and microscopy and culture if they've been abroad recently. One key point in infection control in intensive care is to take out unnecessary lines, and always ask yourself the question, do they need the line? And if not, take it out. If you can, try and convert patients from central lines to peripheral lines, because peripheral lines do not cause as much septicemia as central lines do, and it's much easier to detect an infection in a peripheral line than it is in a central line. Alongside that, always monitor any line insertion points, and if there is any erythema that's starting to develop, take that line out. Do not risk it, because you can get quite deep-seated infections very quickly from these. And the final thing is antibiotic stewardship. De-escalate your antibiotics as soon as you can, and stop antibiotics after a defined period of time. That is very much going to go hand in hand with the discussions with the microbiologists, but bear in mind that these patients could be on multiple antibiotics throughout their intensive care stay and can develop quite resistant organisms if you don't treat your antibiotics very carefully and only give what is needed when it is needed. There are a few things that are commonly missed, especially by juniors on intensive care doing ward rounds. The first is leaving lines in unnecessarily. Although it may seem easier to have a central line in so that the nurses can take bloods and give multiple medications, actually they're a great source of infection, and as such, if the patient is not requiring medications that need to go centrally, then put in the adequate number of peripheral lines if you can. When you're doing blood cultures, it is always better to do peripheral blood cultures. The one slight proviso to that is if you're worried about line infections, then take a blood culture through the line before you take it out. But the most important thing is the peripheral blood cultures. Do remember that urinary catheters can get infected, and so they do need to be changed, and even long-term catheters are changed regularly, and it's worth checking what type of catheter they have in place and then checking the manufacturer's guidance for how often they should be changed. In general, every month or so a catheter should be changed, but be guided by the guidance from the catheter company and also from your local policies. Remember that DVTs, deep vein thromboses, can present as fevers, and so if your multiple septic screens are coming back negative, do think outside the box and thoroughly examine the patient to see if there's any evidence of blood clots that may be driving the temperature and the low-grade inflammation that is often seen. And the only way to pick up pressure sores is through thorough examination. Now, of course, nurses will usually alert you to these when they're washing patients and turning patients, but it's always worth you to specifically look for them yourself, because if they are missed, they can become quite deep-seated, and then if they get secondary osteomyelitis, you've consigned that patient to months of antibiotics and potentially multiple surgeries unnecessarily. So in general, the key thing is a thorough examination. Look for the source of sepsis and then culture everything you potentially can. Preventing infection is much better than having to deal with the consequences of it. So the really important slide is the infection prevention and all the different steps that we can take to try and reduce the risk of our patients developing infections, and especially multi-resistant infections.